I am going to talk about focus on high dose patients. What we all agree is that medical imaging is immensely useful, and every publication, every presentation is pointing to that. Also, we are clear that not performing a needed exam can have more harm than predicted radiation harm. And talking about the risk does not diminish usefulness, but it helps in appropriate benefit risk assessment. We many times hear this statement: if I am prescribed a CT scan by the doctor, I will not think a bit about the radiation risk. This may be true in many cases, but we need to recognize that we or they who are dealing with this statement are not among those in whom cumulative dose is of concern. So we are not talking about doses in a single or double digit of millisievert of effective dose or milligray of organ dose, but in 3 or 4 digits of millisievert or milligray to an individual patient. It is way back, not too much far way back, only in 2018, when we asked about 3 digits of millisievert. This will lead to just a big surprise that most of the time people will think that such patients with high doses may only be absolutely in very few number. But this is what has been the findings from recent literature. We have 3 studies which we published recently, and the overall finding was that likely 250,000 patients every year in US are having cumulative effective dose of more than 100 millisievert from CT imaging alone. That is, it doesn't include the nuclear medicine imaging, fluoroscopic guided imaging. So by any definition, whether by NIH, NCI, this is not called rare. So the 3 publications which came from our group, uh, some of them involve participants from all over the world. These 3 papers were published in European Radiology almost at the same time, within 1 month. We dealt with the editor-in-chief and told that this is going to be a very large study, and we will publish them in 3 parts. So what do these 3 papers contain? Initially, we have had data from Mass General Hospital, where I work. We had data through radiometrics for 5 years, 5 sites of the MGH, 19 scanners, and 267,000 patients. So it is not the number of scans, but patients. I highlighted that with red because many times information we have from literature and from most places pertains to the number of exams, and number of patients is difficult to find to correlate the exams and patient. So initially, when we did the study only from MGH, and we found almost 9,000 patients with more than 100 millisievert, I did not jump to publish the results because I felt that if we do so, people will say, oh, MGH is not an ordinary hospital with a lot of clinical trials, very sick patients, very complicated patients. So I wanted to do a large study. So I asked one of my colleagues in Orlando, Dr. Bill Senmansko. He also had the access to the data from Radiometrics, and he had from the Advent Health 16 sites with 35 scanners, almost 500,000. Then Slovakia had a national setup where they have the national data from 5 years. They had 108 CT scanners, 70 and 0.8 million. Then we also, through Imalogics, who had installed their dose management system in 252 hospitals in USA, and they had 326 scanners data, almost 1 million. So total 2.5 million patients data we had. What we found is the number of patients who were receiving 100 millisieverts or more of the cumulative effective dose were 3.4% at MGH, Orlando 1.4%, Slovakia 1.5%, and the 252 hospitals, 0.64%. This is understandable because this includes hospitals, not only tertiary care hospitals or specialized hospitals, but at a lower level also. So that will imply that whereas most of these will have tertiary care. So like here we had maximum number of CT scans, 109 here, 57, 67, 89. Median number of CT exams per patient, 19, 11, 66. Mean number and median cumulative effective dose of 147 here, 130, 130, 125, and the maximum going near 1000 of the. So the immediate impact of these three papers was that there were 6 editorials in 5 journals listed here, which came up. And just to remind, yesterday also some of the speakers talked about gave reference to A-bomb survivors. More than 60% of the exposed survivors in A-bomb received a dose of radiation less than 100 millisievert. So people normally tend to think that A-bomb means huge doses. That is not the case. So as you can see from this. So what we know now is that nearly 1 million or 2 million patients are likely getting added every year globally with cumulative effective dose of 100 millisievert or more from recurrent CT exams. I want to share with you my own personal feeling, which I had at that time. So I felt that there could be something wrong when we are having such large, unimaginable numbers. So I doubted our own results. So I felt, could there be an error in our calculation or extrapolation? Is this figure, whatever we are talking of million, for 5 years or 1 year? We talked to more statisticians, and also how come no one else had ever been able to reach a similar conclusion before. I can share with you the experience I had in ICRP in 2019. The meeting was in Adelaide. When I presented my results at that time, none of the about 20 members of Committee 3 of ICRP dealing with medical radiation protection could believe or imagine that such numbers could ever be possible. Everyone used to have a feeling that 100 millisievert, oh, it may be 1, 2, 3, 4, 5 patients in a year in their hospital, nothing more than that. So these numbers were something unimaginable. So I told them I have such a huge data that can guarantee you if you go back and do assessment in your hospital, you will find the same results. And that is what they did, luckily, and we had the similar results. So luckily, I could spot from ICRP itself one biostatistician from Committee 1 of ICRP, and I shared my data with him and asked him to check for correctness. And also we tried to, when he found that the calculations we had made were correct, then we used those figures for extrapolating data to 35 countries in the OECD region. And this is what came out. United States on the highest side, then followed by Japan, Iceland, Luxembourg. On the lowest side were Finland, Slovenia, Italy, Ireland, and all that. So these are the estimated number of patients in 5 years with more than 100 millisievert per 1,000 population of the country. So inferences from the large studies were not, we are not saying that imaging was not justified. So this goes in a way different from the previous time in 2003, 4, 5, whenever such studies were brought out, the finger was pointed out that on just lack of justification or lack of optimization. So I will talk more about it in the coming slides, but I don't want you to go with the feeling that this simply means that the imaging was not justified or not optimized. We are not saying that the patient did not receive benefit. What these results indicate that recurrent imaging and doses more than 100 millisievert of cumulative lactidose is not rare. So what is new? Because these publications of this type have been around since 2009, and I refer to Aaron Dixon's good work, which he published in 2009, which yesterday he made mention of. So the difference between 2009 and till 2008 is projected in this slide. So most publications during that time were single hospital settings or in a single disease condition. Many of them were in a single disease condition. So with that, it was not possible to extrapolate the results to national or global level. And what was needed was the large scale studies with millions of patients, multicentric, multinational, and population based studies, means all patients undergoing CT in a hospital, not only those with a defined disease. So that was a difference that it could help us to extrapolate the results to others. Beside the 6 editorials, which I mentioned a few minutes ago, the impact was that now there are more than 300 citations of these papers, about 50 new publications in the last 3 years, and 2 position statements, one headed by the IAEA, also WHO, and a large number of international professional societies supporting the IAEA statement, and then AAPM, HPS, ACR, supported by some other national organizations of the US. So the chain reactions of these publications from the European Society of Radiology decided that they will give highest priority to this topic. So they did survey in 19 European countries and they published their results. Their results also indicated around 0.5 or 0.6% of the patients with the cumulative dose of 100 millisievert or more. Then this was a paper from Netherlands, probability of receiving high cumulative radiation dose in 5-year period. So which patients are prone to undergo disproportionate recurrent CT exam in 2020, then 2022? How much should we be concerned about the cumulative dose? So this was the UK study in which they were absolutely not thinking that they will have, because in ICRP, UK's person was also there, and Germany, they were thinking that in their country it cannot happen. So luckily I could motivate them, and they did study, and they found that their results are also within the range which we provided. Another study from Canada. This is another from Austria, again with 100 millisievert. In addition to assessment of the load of these patients, there have been number of papers on the dose management systems, which have helped people to find these patients. So there have been papers on the comparison of patients' effective dose from multiple CT exam based on different different calculation methods. Yesterday, Dr. Rebecca Smith Binman mentioned about this work in which they found that DLP to effective dose conversion coefficients are not too bad when they compared with the Monte Carlo estimations. Then this paper again from ESR talking about the requirements and recommendations for users of the dose management systems. Risk surrogate, dose management system systematic review. And then there also have been during the last 3 years papers similar to those which were there from 2009 to 18 in specific conditions, like in COVID-19 patients admitted to ICU, COVID-19 patients, also occupational accidents and intensive care survival, patients inflammable bowel disease. So these are many of these conditions. There have been number of publications in the past also. A special focus issue of British Journal of Radiology of October 2021 on contemporary issues had 6 papers on recurrent imaging, and they surveyed the situation on recurrent imaging in the recent months. Going over to the organ doses, we had this cohort of patients with more than 100 millisievert, and we looked at the organ doses. We found that the mean dose for each organ was more than 100 milligray in all organs. Some organs, the dose was more than 200 milligray, and these are stomach and liver, and those between 100 and 200 milligray are these 9 organs listed here. And some other organs, significant percentage of them had more than 100 milligray. Typically, when I have a chance to interact with the audience, this is a question I ask them. What is your guess about the minimum time for a patient to get 100 millisievert through recurrent CT exams? Something like 1 year, 6 months, 1 month, and hardly anyone is able to pick up the last one. So this is where we found something strikingly, that in all the 4 centers or a group of the centers, the minimum was 1 day. This was totally a new finding, which was never reported before, that 100 millisievert in a single day. So when this finding was there, so I felt that there are millions of patients. Out of millions, even if one patient may be there with more than 100 millisievert, that doesn't make much of sense. So I thought, let us settle this issue as to how many percent of the patients or what fraction of the patients are getting such high doses in a single day. So that is why we did a very large study again. This is the study which we had published in 2021, in which we had data from, again, some 4.3 million CT exams in 3.9 million patient days from 262 hospital. And we found that 0.8% of the patient got more than 50 millisievert through a single exam. So this was through a single exam. So practically 1 out of every 125 patients get such high doses. And then 0.03%, that means 3 out of 10,000, 10,000 with more than 100 millisievert in a single day. So that gave us a feel through a large study as to what is the overall situation. And 9.4% underwent more than one CT exams in a single day. Nearly 1/3 of those with more than 50 millisievert in a single exam were below 50 years of age. And we identified top 20 CT protocols that led to 50 millisievert in a single exam. I'm not going through all those details, and the paper provides all these CT protocols. Well, with that, another Italian study also had done this in a single episode of care, patients with high millisievert. With that, we went over to PET CT also besides CT. And this is the publication we made in British Journal of Radiology in 2022. And we found that 1 out of 5 patients had more than 2 PET CT exams in a calendar year. So this is only MGH, so single hospital study. And we found that 12% were below 40 years, 27% 41 to 60 year, and largest fraction of 61% are in the more than 61 years. So we found that 1 out of 8 patients received cumulative effective dose of 100 millisievert. So that means around 12% of the patients. And if you remember the figure a few slides before with CT, we had 0.5 to 3.6%. So this is much larger percentage of patients. There is another study in which it is 1 out of 4, so 25%. So it's a much larger fraction. So this is another paper from Italy about the nuclear medicine studies. Then we moved also to the fluoro-guided interventions. So this is the paper which we published in 2020. This is again from MGH alone. We had data of 9 years from 12 interventional radiology rooms, more than 46,000 fluoro-guided interventions, and we estimated the dose from CAP. We found that 4% of the patients received cumulative effective dose of more than 100 millisievert, cumulative effective dose 100 to 1041, and median was 177 millisievert. 42% of the patients received cumulative effective dose only in one fluoro guided imaging investigations intervention, and 79% patient underwent all procedures within 365 days. So what is still unknown is the total dose from all the imaging modalities combined. We have one publication which is at a fairly advanced stage, again from our own hospital, but large scale studies are lacking there, also in imaging and radiotherapy, only in specific conditions. So to summarize, what I have talked about so far is the number of patients likely getting added, and then how many with more than 50 in a single exam, how many 100 millisievert in a single day, and similar data from FGI and fluoro, and the total dose is. I will now go over to the other part. So, of course, what if anyone in our family or loved one faces this situation? So we often have hear this statement: the patient with such doses are those with malignant disease who get mega quantity of radiation doses in any way, so why worry? So this is absolutely incorrect way to think, and unethical also, because patients with malignant disease get radiation dose to the tumor cells, not to the whole body of the patient. This is even many of our professional colleagues talk exactly the same way, that, oh, these radiotherapy patients are getting a lot of radiation dose. They don't realize that it is a very small defined area of tumor where radiation is given deliberately, and medical physicists are employed to ensure that the rest of the tissue by outside the tumor does not get any dose or minimal dose. Of course, it is not possible to avoid any dose. Industry spends billions of dollars on machines to ensure that the normal tissues outside the tumor are not really getting any significant dose. So it is not the patient, but the tumor which gets huge radiation. So this is a clarification which one should have. Another common statement we all hear is justify each exam first and then optimize the exam, then patient safety is achieved. So this is something which few years ago, any paper with high doses, the finger will be pointed at unjustified images or unoptimized imaging. So let us look at data. We analyze this issue. I'm sure most of you know that at our hospital, MGH, we have a clinical decision support system. And MGH is a leader in that CDS system, having started it way back in 2005 or even 2 years earlier. And the technology has been passed on to ACR, which has established a new private organization, and that is how it's going on. So every patient goes through the clinical decision support system. So the best form of mechanism available for justification is utilized. And again, at MGH, we have the ACR dose index registry values, and we compare with them, and almost in all these cases, the values are 38 to 89% lower than the national benchmark. So with that situation, despite using the best system available today for the clinical decision support, that is for justification, or the optimization, comparing our values and keep with the ACR dose index registry as a benchmark, and keeping them much below that, still if we find ourselves at such values, so that can our current day system of justification stop this from getting doubled in 10 years? So this is a kind of worry we have. So it all leads us to feeling that the industry needs to provide scanners with much lower dose. Another point, decision to perform a medical imaging exam should be based only on the clinical grounds and not on the dose from the prior imaging. So this comes from exactly the statement from the AAPM and statement by others, supported by others. So in fact, the risk benefit is something which needs to be always kept in mind, and benefit more than the risk. So if we say that what we have seen in the previous statement, the decision to perform a medical imaging should only be based on the clinical ground, including the information available from and not from the dose. That simply means that you close the eyes to the risk and do only benefit assessment, whereas the principle is risk benefit. So that way, this is the fallacy in the statement, that which means that there is no risk benefit but only benefit. On the other hand, European Society of Radiology has a different view. In their publication, they talk about how to reduce the number of recurrent exam. They talk about risk benefit, informing them about the patients, about the cumulative dose, establishing list of clinical situations where recurrent CT examinations are undertaken, set a dose tracking system, provide the physician requested. So all these things are on the European side, whereas in that statement, it mentions that do not look at the risk side and only talk about. So this is a big discrepancy, and this needs to be handled. What do referring physicians think? This is an important aspect, because hardly ever one asks referring physicians. So this is one publication which I will refer you to. They talk about a model they are suggesting, in which that all body CT, head, chest, this it must be considered controlled imaging, like the controlled drug system. So they want that the use of all control imaging modalities should be monitored at an individual prescriber and institutional level. Radiation risk stratification of an individual patient based on cumulative burden of controlled imaging modality over the. So in essentially they are talking about having some separate category of patients like they have for controlled drugs. Also, we had done a survey with the referring physicians, not radiologists. Absolutely, these were only referring physicians. 505 physicians from 25 countries. So should there be regulation to limit the number of CT scans that can be prescribed? So no was said by 28%, maybe 36%, yes by 33%. Most respondents think that radiation risk should be form part of the consideration when deciding whether to request a CT exam. A minority think the decision should be based only on the medical indications, only on that. So the conclusion from this study was a majority of the surveyed clinicians consider radiation risk in addition to the radiation factors when prescribing CT scan, and they would be fine with regulatory aspects. But I want to make it clear that at the moment, there is no proposal from international organizations like ICRP or national organization and IAA to introduce any dose limit for patients, and there is no recommendation to use a defined value of cumulative dose to stop a needed examination. And finally, patients with high cumulative doses have short life expectancies. This is a statement. This is a false, because there are a number of situations with long life expectancy, and the patients can get many more exams. There is a scientific data to show that cumulative doses have led to refusal of this examination. This is a question, of course, and absolutely we have now not found any evidence of that. So the message is that cumulative dose data has been available via thousands of dose management systems installed in US and Europe for many years without any evidence suggesting that the information has been misused, or if it has prevented the necessary exam. On the contrary, there is a paper on experience from Finland where they have been using the dose tracking, and they have shown how it helps in justification and optimization. So essentially, it is a question of exam or patient. Like yesterday, when Aaron was talking about the drop size. So every time we were fixed on exam dose. So all lectures in the previous years have been on exam dose, single CT exam dose, whereas we are talking about the patient dose. So, and that is what the shift in focus needs to be. So from exam dose to the patient dose, while of course maintaining the focus on the exam dose. We have a short history of the imaging of only 128 years after Ronjan's discovery of X-ray. So was there ever a time when the situation was like this? Obviously not. So actually we are in an unprecedented era now with such, and as Aaron was also talking, that things are likely getting worse. So we are likely to have more and more. So in 5 years' time, we might have double the numbers. So recurrent imaging, how much is the question? At the moment, we do not have clear answers. So at the moment, the current policy is that for individual exam, only as needed for clinical information. For series of exam, there is a lack of adequate guidance, both on justification and optimization. Suggestions in literatures have come around, like the physicians talking about controlled drugs. There have been talk about traffic light kind of a situation. At the moment, it is only green light, so there needs to be yellow light added. If not the red, need for better information on correction factors for repair in recurrent imaging. That's for radiation biologists. Age-related radiation sensitivity factor, again for radiation scientists. Life expectancies for disease-related factors is our current information on dose versus risk, correct? So these are all radiation biology and radiation scientist people, they need to handle this. And implication of the cumulative dose research is that it has created focus on patient safety, not just on technique optimization. It has provided compelling agenda for industry to develop safer imaging machines. The identification of conditions in which appropriateness criteria are not available from ACR, that came from one of our papers. And we found that 1/3 of the conditions did not have the ACR appropriateness criteria available. Identification of what clinical condition lead to frequent imaging. This is again what we have put up the list in our papers also. Need to create balance in emphasis between tissue reactions and stochastic risk. Sometimes one gets a feeling that tissue reactions are overplayed, whereas stochastic risk have been downplayed. Urgent need for research on radiation effects, urgent need for imaging guidelines for recurrent imaging, specifically urgent need for ICRP dual recommendation for protection of recurrent imaging. In conclusion, if studies on cumulative dose were not done, we will not know the magnitude of the doses involved. We will miss millions of patients with such doses. The patients need more CTs. That is absolutely correct. All the time we feel that generally there are situations which require more CTs and other imaging. So it is, the purpose is not to stop or reduce the imaging, but to really rationalize and to make the patients safer who have to undergo a large number of images. So we need to push the industry to make imaging safer. Thank you very much for this patient listening, and let me go over to the question.
Thank you so much, Dr. Rehani. That was really outstanding. It's exciting work. I know anybody from our research team who's on the symposium right now is excited because we've also recently started looking into this in our registry data. And we're finding that around 1% of our registry has a cumulative effective dose over 100 millisieverts. And that's also, we know that that's just the floor too, that these patients might receive imaging outside of the hospitals in our registry. And also our registry is only counting for maybe a period of 5 to 7 years. So how have you considered that in your research, the fact that patients get imaging outside of your observed hospitals?
We decided to close our eyes to that part. That is how we could continue doing this research. Otherwise, for many years, I was wondering if in US a permanent number may be available. Many countries assign a permanent number to individual the moment the child is born, and that number remains valid for life. And they use that number for medical records. So US doesn't have that. Now there is a PMRN number which has come up. Even in EPIC, you will see in your systems. beside MRN, you will see PMRN number also. So in US, at least ultimately, we do have something coming up in a reasonable manner on PMRN number. So once that becomes effectively available, so then it will be easy to achieve the accounting for all exams done at all facilities. Yeah.
That would be great. Some questions have come up in the Q&A. Do you want to read them?
Yeah, let
yourself,
me
or-
read the
Oh,
first one.
okay.
John Pachon, is high cumulative effective dose tracking linearly with increase in patient acuity? What are some of the main drivers of higher cumulative effective dose in less than 1 year window? I understand we are ordering more imaging procedure, but it is because patients are sicker, or is it just convenience? Well, difficult question to answer in a simple manner. There are every factor is playing. For example, one of those three papers which I projected looked at this aspect as to first, how much was the appropriation of the imaging? We found that 85 to 100% of them were considered appropriate by independent clinician who looked at the file of these patients. But the interesting finding was that more than 50%, nearly 50% of the imaging in these patients was not for the primary disease. If the primary disease is follow-up of a cancer or the irritable bowel syndrome or anything, so nearly 50% of the imaging was for reason other than the primary disease. So this was interesting finding. It may be trauma, it may be infection, it may be any other condition. So it's a quite a complex issue to deal with and to find, but it varies a lot. So whatever little work we have done, we find that it varies with lot of conditions. And we can say that justification and optimization was in place at our hospital, but in large number of hospitals, that may not be the case. Let me read the question again. If I have attended to the question, I understand we are ordering more imaging procedure, but it is because patients are sicker, or is it just convenience? Yeah, we cannot say, I mean, for our hospital, if we say that clinical decision support system is looking after that aspect, so we will say that it is appropriate. So it is means patients do need. Although human factors are always playing the role, convenience and all, so physicians may be keeping that in mind. It may not be explicit, but everything plays its role. Second question, Dr. Samir Tipnis. Thank you for the illuminating talk. The practical question is how to assess the cumulative dose when a patient comes to the clinic. We do not always have access to these prior scans. Radiation dose history, they could have had multiple scans at different imaging centers. How do we tackle this if the cumulative dose is supposed to be part of the decision-making process? So first part I have already answered when Carly mentioned about this. So it's a matter of time now when the permanent MRN number will get implemented widely, and also the dose tracking system. So it won't take many years now, the way we are. So it will become possible in the near future. Regarding the second part, if the cumulative dose is supposed to be parts, this is where we have been stuck up at the moment. There have been a few meetings at the IAA on this topic, but at the moment, I don't think I can say anything is available to guide that. So how to use the cumulative dose in the decision-making process. This is a work in progress. I think I will leave it there.
Okay, I have to mention that I've actually been fact-checked by our lab. I mentioned that 1% of patients in our registry have a cumulative effective dose over 100 millisieverts. That's not correct. It's 1% of exams in our registry have a single dose of over 100. So
okay.
We had one more question come up, which is you showed us the ACR criteria, appropriate use criteria for when to image based on indication. And we've seen that there's a numerical writing beginning with usually not appropriate up to appropriate. I forget what the exact scale and wording is, but it seems that there's no recommendation, do not image. And do you think that that would be useful to have that included in the spectrum of AUC recommendations?
It does talk about in that, I mean, not using the word do not image, but it does imply that usually appropriate, usually not appropriate, and consider others. So it goes in the same direction, although not that strict formally as the word you are mentioning. Not so. Um, Maybe with time, when the situation becomes much worse than what it is today, this also could be one of the way, but I don't see the mindset in US is do not stop imaging. So I have lived in Europe also for a long time. So in the US, the trend is different.
Okay.